right, so I've been invited here today to talk about nutrition and particularly what nutrition needs to be known for ICU nurses. So if you're interested in the packet handout, it is available and provided. And I just wanted to take a moment since we're recording and say, who am I? Why do I have the authority to sit here and talk to you guys about nutrition? So I'm a registered dietitian, which means I've gone through at least a bachelor's program, which is what I went. It's at least 2 years of very specific training about metabolism and nutrition in general. Then you go through an internship, which I did at the at the University of Montana, which was across the state. St. Pat's is where I did my most of my internship in Missoula. Since that internship, I have gone on and got a certified nutrition support clinician certification, which is another one. You have to have 2 years of practice in the field, and you study and you take a damn hard test that is for everybody. It's not just for nutritionists, it's for physicians, it's for pharmacy, but it is primarily taken by RDs, but we have to have an understanding of what everybody's looking at. So that's a good one to see, and if you see that in other hospitals that they have the CNSC certification, they are really experts in what they're doing. So beyond that, before I went into a second career to become a dietitian, I was a chef. I cooked for over 10 years in the industry. I pursued a professional certification from the Cordon Bleu Culinary Arts School. So it really ties in with nutrition. It's not just I'm talking about the nutrients. Yes, you need more B6, but that doesn't help if we can't figure out how do I get that? What do I need to eat to get more B6? Okay. So that is me. So today we're going to talk about malnutrition, refeeding syndrome. We're going to talk a little bit about nutrition support. It didn't make on this list, but it's in there. And what are the diet orders that we use, and a new upcoming change to our diet orders called the IDSI diet. And then we'll have some time for questions, and I got a couple beforehand. We'll try to address them in the presentation, but please ask questions. Please stop me and ask questions. So malnutrition is the first piece that I want to talk about. When we think of malnutrition, we think of the little African baby naked, crying, because they haven't had food in, years, basically. So, or they have very little food in that time. Malnutrition is a spectrum. It's not just one particular disease, or I'm sorry, not disease, one particular instance in time, or it's a little harder to define. So we look at malnutrition having, 3 etiologies. That it's starvation related. That's the baby in Africa. That's the homeless person living on the street in a tent that, can't get food or don't have the resources, have no place to store it. But starvation related can also be, an eating disorder. And it could not, necessarily be anorexia, but it also could be, other unspecified, as the diagnosis. It could be something we call orthorexia, where somebody is so fixated on proper eating that this has this nutrient and that's going to make everything better, they're ignoring the rest of nutrition. Anytime somebody cuts out a whole category of food, that unless, you're lactose intolerant or you have a true allergy, you cut out milk. Well, there's something that we're giving you in milk that may not be as prevalent elsewhere. Or I don't eat fruits because they're high in sugar and sugar's bad for you. That's one I hear quite a bit, and it's like, okay, wait, now we really got to talk about this. So that can lead a little bit more on that starvation side of malnutrition. Chronic disease-related nutrition. This is your COPD. This is your little tiny lady that weighs, 60-some pounds because she's working so hard to breathe, she can't eat enough. That's the chronic disease ones. And chronic disease, we're really looking at something that's been prevalent for more than 3 months. It can go, we have different categories that we look at for malnutrition. The acute injury or illness is under 3 months. Usually that's within the last week or the last few weeks. Something's happened. You just went for you had a bowel rupture, and you have a piece of your intestine taken out, and you're here at the hospital. So it's been 7 days. Well, that's enough for me to say you are malnourished at this point. You're not maybe as malnourished as that man living in the tent on the streets, but you are malnourished for where you're at and what state you're in. So the prevalence of malnutrition in hospitalized adults is around 50%. That's the high end. Sometimes it's down in the 20s. It depends on the population, and that's why I gave you the data and the information here. Malnutrition is highest in our older adults. That's why I picked the picture that I've got here. You look at the gentleman and you think, oh, nice old man. He's kind of smiling. Maybe he doesn't look so great, he might be a little rough. But the things I noticed is look at his clothes. His belt is looped through, his pants are hanging. I mean, that to me is a good sign that something's not right. He used to be a lot larger than he was, but potentially this is another homeless situation. Is this the only clothes that he's got? And he stayed the same size. But it's about having that kind of critical thinking and start going, what's going on? It's being curious. So malnutrition has a set of criteria that both ASPN, which is the American Society for Enteral and Parenteral Nutrition, so that's our nutrition support when we're really talking about it, and the Academy of Dietetics, they've come together and said, this is our framework. This is how we diagnose malnutrition. Your guys' role in that is in that nutrition risk screen at admission. They ask, a series of 3 questions. You're answering, has there been weight loss recently? Has they, haven't eaten very well in the last week? And then you get a piece of it. You get to decide of how sick this person is. If this person's truly sick, we've got an end of life, not maybe end of life, but end of disease state COPD patient. Yes, they're very sick. If this is a brand new diagnosis, they're not so sick. They might need a little bit of help, but they're not really there. And one of the key pieces that we see is, like, if you're truly in their ICU patient or in their telemetry, we're looking at them a little closer. So regardless of what you pick, we're looking at everybody. But if they're especially down in the ICU, we're looking harder because we know these are our sickest and most fragile patients. Any questions so far? Okay. All right. So nutrition support, that's a big category. Nutrition support can either be oral, enteral being a tube feed, or parenteral, that's your IV feeding, your TPN is what we usually use the language. And that language is changing around TPN. I guess sorry guys, I should back up a little bit and talk about terminology. So I'm going to start using some terminology through here. We're going to talk about macronutrients. Those are your carbohydrates, your fats, your protein. Those are your macronutrients. And then we talk about micronutrients. Your micros are your vitamins, your minerals, your phytochemicals, the things we don't need in large amounts. That's why they're macro and micro. So there is a difference in, when we're talking about physiology, there's a difference between digestion and absorption. Digestion is the chemical process going on in our stomach. Kind of one of the funny things in my A&P class when we were talking about the GI tract, and hopefully you guys heard it, we're a giant donut. We think about our stomach being inside of us, but it's actually outside the body. I know. Doesn't that make your brain hurt? We are a giant tube with a couple muscles, small, sphincter muscles at the esophagus and at the rectum. Beyond that, it's outside the body, even though it's inside our body. So there's a difference between digestion, is that chemical process that is happening outside the body, and absorption is where we get the actual nutrients inside the body. That's when it's passing through the GI into the bloodstream. Okay. And metabolism is the last one I want to talk about. Metabolism is actually using the components that we get. It's using our macro and our micronutrients together to give us the energy to do the things that our body needs to do to move the muscles for me to sit here and talk. Okay? Okay. All right. Sorry. I got a little out of order there. So nutrition support, oral, enteral, parenteral. Oral is ideal. That's what we're used to doing. We want to eat. We want to eat. We ideally eat 3 meals a day, maybe a snack or 2, depending on our lifestyles. But we know that doesn't work for everybody. You'll hear people constantly, I don't eat breakfast. I don't like it. It makes me nauseous. You're like, okay, so you don't eat breakfast. When do you eat first? That's the next thing. And also, we use language. We have to be careful and intentional with our language. Because I ask, what did you eat for breakfast? You're thinking, well, I don't eat bacon and eggs, so I didn't eat breakfast. But you have a Bennett bar in front of you, and that was breakfast. Breakfast is the first meal of the day. So it's what did you eat last, or what is the first thing you eat in a day? So like I said, we want to be able to eat as much as we can. We run into dysphagia diets, swallowing issues, which we know those are barriers to eating. But we can get enough nutrition in it if it's accepted. That's a hard piece of it. So ideally we want to feed, normally. Then we get into, you can't feed normally, or the patient's not alert, or we're on a ventilator. Ideally, we want to use the GI tract. So that's where enteral nutrition comes in first. We want to support the GI, the GALT is what it's called, the gut-associated lymphoid tissue. Yes, I have notes over here because I have to make sure I say it right. So you have an intubated patient. Ideally, the standards out there, I'm sorry, they're not standards, they're guidelines. Standards are a little different. You've got the hospitalized standards in your packet here for nutrition support for hospitalized patients. Those are the standards. We have a policy in place. We have, the head of bed is raised at 30 to 40 degrees to prevent aspiration. Those are the standards. Then we have the guidelines, and the guidelines are more the if-thans. Ideally, we want to feed within 24 to 48 hours of intubation or admission. Because we've noticed that the GI integrity starts to break down at that time. We need to fuel the cells that live inside of our GI tract to keep them, the tight junctions, tight, to keep the bacteria out, because that is outside the body. And as the tight junctions, the gaps get a little bit looser, then bacteria can translocate from the GI tract, and we know the bacteria is, just rampant in our GI tract. Can make it into the bloodstream or can cause other problems. So we want to maintain that integrity. And then secondly, it stimulates the blood flow if we're feeding in the GI tract to help maintain things and keep things working as appropriate. But beyond the GALT, that gut-associated lymphoid tissue, there are chemicals that are produced inside the gut that help us maintain the rest of our mucosal layers. It helps us maintain our lungs. It helps us maintain our oral cavity. So we do want to feed within that 24 to 48 hours if appropriate. We'll talk about appropriate just a little bit. So I put the 3 tube feedings that we currently have available on our formulary, so that's a lot of questions. Why do I pick what I pick and when do I pick it? So our fiber source is our big, what we call polymeric. So it's a large molecule, so that means it's complicated proteins. Proteins are a big giant tangle of yarn that your cat played with. And they, in your stomach, they start to what they call denature, they start to unfold. So right now with the fiber source, it's that big giant tangle, okay? Fiber source does have its fiber in it. It's also considered what we call like a regular formula. It's the closest formula we have to regular food, okay? I'll give you guys a sec, you're writing quick. The second formula on the list is the Nutrin 2.0. The 2.0 refers to the concentration of the formula. Fiber source is a 1.2. You guys don't really see that. You might see it on the label itself, but it just kind of comes and goes. You made sure fiber source HN, and that's what you're hanging. We're good. It applies how concentrated the formula is to how much water it has, because we are providing free water inside the formula itself. So Nutrin 2.0 is more concentrated, so it's better for somebody that is, we're worried about fluid status. We got a fluid overloaded patient at this point. So we likely want to try to switch to this, but it comes with some downsides. Nutrin, because it is so concentrated, it has higher fat content, because that's where we get the most calories out of our food, is from fat. There's 9 calories per gram in fat as opposed to carbohydrates and protein where there's only 4. Alcohol runs right in the middle, about 7. So you really can drink too much and gain weight. We've seen that, yeah. So it's the fat content that can be kind of a detrimental, especially if you have somebody who, pick on the disease state. You have a patient with diabetes and it's been uncontrolled for quite some time. They've got some gastroparesis. Things are not moving as appropriate. So the higher fat content and the higher protein content, the more things hang out in your stomach. You have chemical sensors inside your stomach that can test the type of food that you just ate and how fast does it need to contract and open that end, that pyloric sphincter, to get things to the intestine, because your stomach's job is to regulate the flow. That's your flow regulator, and to mix things up. And with the chemical testing, like I said, it knows what's in there, so then it releases the nutrition down into the intestines at a controlled rate, so we hopefully get better absorption. Okay. One other downside to the Nutrin is there's no fiber, which is not always a great thing. We'll get through this piece and we'll talk a little bit about fiber. So our last one is our Peptamen AF. This is what we call Nutrin is one of those polymeric large molecule ones. So Peptamen is what we call a semi-elemental. So Peptamen is where we've taken the protein and we've untangled it a little bit and we've cut it into usable chunks. You could tie a thing around your wrist. And then you get to true elemental, and that's the tiny amino acids. That's not a formula we carry here. It's a harder one to get coverage outside of the hospital if we're going to use it, and frankly, if they really need it, we can get it, but they're not going to stay here. They have other GI issues. They're typically have moved on to a higher level of care at that point. So semi-elemental, the protein is broken down a little bit. It has some fiber, but not as much as the fiber source. It is a high protein tube feed. And there's a little bit of controversial you hear about kidney disease, we don't want to give too much protein. So yes, we hear that. We hear that from the nephrologists. We want a low protein diet. And you're like, okay. I sat through a 2.5-hour lecture about a low protein diet, and I'm like, okay, I'm here for continuous renal replacement. Okay. He gets to the very end of his presentation, and one of the dietitians, she finally raises her hands and she asks, so what does that mean to you, sir? And he's like, oh, that's a 0.8 grams per kilo. And the whole room went, oh my God, that's normal. That's the normal recommendation. We're looking for a 0.8. We get into the technicality as being a dietitian. We're mathematicians, unfortunately. You think when you're going to school like, oh, I'm going to learn all these great things, and I'm going to counsel patients about what they should eat, and then you get to your hospital setting and you're like, where's my calculator? Because that's how much math you're doing, making sure that what is the disease state? Are we meeting their nutrition requirements? Then we get into micronutrient requirements. We're suspicious this person has a vitamin C deficiency because he's homeless and off the street, and he's bleeding really easily, and he has the little purple spots all over his skin. Then I'm worried about how much vitamin C does he get. Then I've got to crunch all of those numbers. So a lot of what dietitians do in the inpatient side is crunching numbers. We're mathematicians. Okay, so I promised we'd talk a little bit about fiber. So fiber has, in tube feeding, has a couple purposes. One, it thickens stool. We want to thicken it as much as we can because tube feeding is naturally thin, which causes a change in stool consistency. It's just the way it is. There's not much we can do about it. So the more fiber we can have in the formula itself without causing problems, clogging the tube. It had gastroparesis. It's also one of the ones that causes delayed emptying. So not just the protein and the fat, but the fiber itself can empty the stomach a little bit slower. So we want the fiber there for thickening the stool. We also want to feed that good bacteria that lives in your colon. And that's what they live off of. One of their primary jobs, your food makes it down to your colon, and your colon's major job is to absorb water out of what's left, out of the chyme. That's the material that's in your GI tract. So the fiber hangs out there, and the bacteria, I think it's a heyday, it's feast time. So they eat the fiber, and they produce a couple chemicals that your colonocytes, the cells in the GI tract, love. And they get first priority because they're the closest. So if we get the fiber to the GI tract, that really helps keep those tight junctions tight because those cells are working appropriately. Okay, now I've covered kind of the tube feeds. Any other questions so far? No? Okay. So let's talk about managing a tube feed. There's some guidelines. The major one that changed, especially here at this hospital, was the gastric residual volume recently. The gastric residual volume, for a while we thought it was great. We really did. It told us how well somebody was tolerating tube feed. Unfortunately, we looked into it, we kept looking into it, and we discovered that, some of the cutoffs that we've got, that 300 mLs, the 500 mLs, most of us are walking around with that in our stomach right now, and we're not being tube fed. You're drinking water, you've got food in your stomach. We put out close to 2.5 liters inside of our GI tract a day that most of it gets reabsorbed. So we're cranking stuff out and we're getting it back in. So the gastric residual volume is also problematic based on technique and position. We know that our stomach is not a nice round ball, it's a nice kidney bean shaped. And if somebody's laying over on this side, are you going to get more? Or they're laying on this side and you're not going to get anything. So we know positioning is also problematic. And then technique for strength. Not all of us are the same strength to pull back on that syringe. Some of us, like me, I don't have any strength in my hands. I can't pull very hard, I can't hang on to it, but somebody else across the table might be able to really reef on it and be able to suck up through the tube. So that's why routine checking of the gastric residual volume is not recommended without other signs. If you've got somebody who's distended, the belly's really, out there, it's hard, it's taut, yes, please check a gastric residual. But please don't just check it because that's on your checklist. What we find is you get a gastric residual volume of 300, which is in our protocols, that we stop. We stop the tube feed. And that's what we're trying to avoid. The more interruptions we have with tube feeding, the less calories this patient's actually going to receive. And then we've got that cascade looking at a malnutrition picture. Okay. There's also NPO around, diagnostic tests or procedures should be avoided if possible. If you're going to transport your patient and you got to move them over to the MRI machine and you're worried about they're going to roll a little farther, yes, please stop the tube feed. That's, just logic. But if somebody's going to come in and they're just taking an x-ray, please don't stop the tube feed. Just let them take their x-ray and move on. We want to reduce that time that they're off the tube feeding as much as possible. We do compensate for that as RDs. We have a pretty standard practice. We do our formula calculations, and we do them for 22 hours. We're expecting that 2 hours of the day, they're unplugged, they're off for whatever reason, they have to give other medications, so we are expecting that. But when it gets beyond that 2 hours, then we start looking at we're perpetuating a hospital-acquired malnutrition, and we want to avoid as much as possible.
But the turning off, like when you put the head down and stuff,
yes,
that differs between your orogastric tube and your jejunostomy tube.
The reduction, the rate of aspiration, we've noticed there is a reduction based on where the tube actually ends. Whether it's in the stomach, your reservoir that has the potential, it's only got one pyloric sphincter to help keep things in the stomach and not up in the esophagus and potentially in the lungs. Whereas if you've got further down and you've got a J tube where it's feeding in the bowel, the small intestine, you've got another sphincter that's trying to help with that. And you've just got distance, period. So you got less time for it to travel up where it shouldn't be.
Do you take that into account when you're doing your calculations?
No, we don't. We don't primarily, we just stick with the 22 hours for the most part, unless a patient has been really stable on their tube feed, they have a highly involved, there's a case that's actually here right now, there's highly involved family, he's tube feed dependent, then I'm looking at the full 24 hours. Because they are there actually administering the tube feed, even though, nursing's doing it, but it's with the family, giving care. So that was one it's a little more odd. I did look at the whole 24-hour picture, because that's what he's used to getting at home. If it's somebody new, I'm really going to think that there's probably a lot of interruptions. I know that they're going for MRI and they're going down for endoscopy. Yes, we're going to try to bump that rate up a little bit to try to meet their nutrition needs. Okay, so does that answer that question? Okay. So that's the next piece about it, is risk of aspiration. That's one of the things. We want to make sure the head of the bed is up. That's, that's the basic one. That the tube is in the appropriate place. That if you're suspicious that the tube is not in the appropriate place, then stop and check. Figure that out. If you can, if you're really worried about it, somebody's not dealing with oral secretions really well, or you notice that there's a little bit of, that white, not white creamy, but kind of tan, looks like tube feed, then we want to consider changing the type of tube to get from a G to a J. Ideally you don't ever see tube feed from a J tube, but it can happen. But likely the tube has, because your GI tract is very mobile. We don't think about it because we learn to ignore it as babies, but things are moving around all the time. You know, lay down, listen to somebody's stomach, or, you know, you have your, I'm used to listening to my husband's, like, wow, that's really loud. You've got your stethoscopes. You know, so you know that it is usually moving around. So there is potential that that tube can be dislodged out of the intestine and coil in the stomach. That usually doesn't happen, but it is possible. Let's see. We know about the blue food coloring, and please don't do that. It's, you know, as a marker for aspiration risk. That's an old school thing that has really not been used in quite some time, but it always comes up because eventually somebody out there's still doing it. So what they did is they added blue food coloring to the tube feed. So it was easy to identify if it made it up into the oral cavity.
Huh.
But
And
blue,
also turn things blue.
yes, it also turns things blue and can be renally toxic, and you know, it's not a good idea.
As a relevant.
We do want to continue good oral health care when we've got a patient that is being tube fed, whether they're fully vented or just a regular NG tube. We want to make sure that the mucosa in the mouth stays nice and hydrated. They recommend that we use a chlorhexidine mouthwash, but those really don't taste well. So they can be resistant to that. But giving, you know, good oral swabs and making sure that the mouth gets cleaned is, you know, just part of the care. So other reasons to not really interrupt is the diarrhea. You know, we hear that all the time. I hear it all the time. This patient's having 8 stools a day, and you know their bum is getting really red because we're constantly wiping it. I'm like, okay, I get it, and then it's the tube feed. And what we've discovered or what we've learned, it's not always the tube feed. What medications are they getting? How are we giving the tube feed? Where it might be a method in which we're doing that's causing the problem as opposed to the actual tube feed itself. We also want to look at the temperature of the tube feed. We're good here because it's shelf stable, but you have a patient that is coming from outside and they're constantly having diarrhea. One of the questions we got to ask is, where do you store your tube feed? Well, in the fridge, because that's where food goes. Well, it hits your GI tract cold at 41 degrees and you didn't get a chance to warm it up inside your mouth, and you just put, you know, 1.5 liters in. Well, your GI tract's going to freak out and it's going to move things along. So you don't ever want to give cold tube feed. So if you happen to have it, you know, stored someplace in a different hospital and you notice that it's coming up and it's really cold to the touch, give it some time to warm up. And that usually takes, you know, half an hour. That's not a huge delay. You're going to have less complications with diarrhea beyond. So we want to add fiber if we're still having trouble. We're on our high fiber formula, it's not so high. And we're still having trouble. Then we want to try to look at actually adding fiber to the formula itself, doing what we call modular. But we run up against the risk of, yes, I've got, we're adding a fiber supplement like Metamucil to the tube, there's potential for clogging. So it's incredibly important that the flush is done appropriately. You know, Metamucil can be mixed in 8 ounces of water, that's what we recommend. If we're worried about a volume overloaded patient, we want to reduce that to 4. But we still want to give that full 60 cc flush at the end. And flushing is the most important piece of it. Most of the time, like fiber can clog a tube, but most of the time we find out that medications were probably not administered as well as they should have been. You get somebody coming from home and their tube's clogging on a regular basis and they're putting Coca-Cola down it, which eats the tube, which is not a problem in the inpatient side because that tube's going to only be there 14 days. It's a problem on the outpatient side. You don't want to be putting Coca-Cola through the tube because it actually erodes the tube and it'll fall apart eventually. It works, it eats everything. We've all done the penny test or seen the penny test. It'll eat your penny. So we'll find that a lot of times an outpatient that has a clogged tube, they have stuck their 3 medications they're supposed to take in their little mortar and pestle, or they've, you know, just crushed it on the counter as best they can, and they mixed all 3 of them together. We just made a new drug, and we don't know how it's going to interact. We don't know whether, you know, one, it's going to coagulate different proteins together that are inside the, you know, right around the tip. We don't know. We want to administer medication one at a time with a small flush in between if you're given lots of medications. And a small flush would be a 30 ml flush as opposed to a 60 ml flush. 30 mLs is enough that we can push the end of the tube out and we're kind of given it, a cleaning job. But the 60 mLs is better. We know for sure that we have cleaned that whole tube regardless of its length. Okay. I wish I had brought some water. Okay. We're going to touch briefly on the parenteral nutrition. This is something, so TPN. We hear that language a lot. We say total parenteral nutrition. It's not total, so the nutrition industry is kind of moving away from that. We just say that it's PN, it's parenteral nutrition, because we've got PPN, peripheral parenteral nutrition, which is given through a regular IV as opposed to some type of central access. So the TPN, the total, has to go through some type of central access because we have the potential of destroying the vein. It has to do with osmolality and how osmotic it is. Unfortunately, as we break things down with amino acids, there's a lot more particles, so it increases the osmolality. Okay. The biggest thing for nursing is handling appropriately, sterile technique. Please don't ever just turn off a parenteral TPN. The reason being is a normal physiological process. So our body gets used to the blood glucose. We have sensors in our brain that tell us to crank out more insulin in the pancreas. So we're supplying quite a bit of calories and everything's going, your pancreas is cranking it out, and well, you just turn it off. And where's that blood sugar going to go? And that can happen pretty quickly, unfortunately. It can take only like 15 minutes. Most of the time it's about a half an hour. Somebody gets a little confused and gets a little lethargic. Be suspicious that we might have a hypoglycemic reaction. That's the major pieces for parenteral nutrition for nursing, and we could teach a whole darn class on it if needed, but okay. Phew. That's a long one. So I got asked to talk about refeeding syndrome because dietitians talk about it a lot. So you get a nice graphic. It's stolen from the article a little further on. I gave you the whole article. It's not super long. It's about 8 pages. It is more in the frail elderly population. This is what the article is really designed for. And then sometimes you'll see in our notes that we're talking about a low refeeding risk or a moderate refeeding risk. This is where we start taking our guidelines from. The downside is to this article, these are very conservative, which is okay. We have an elderly, frail patient. The last thing we want to do is cause refeeding syndrome. Unfortunately, that's not typically how it's managed here in the hospital. We are a little more aggressive, or maybe a lot more aggressive. But we have, most of the time, it's like somebody has a moderate risk for refeeding syndrome here. We have a current patient that is here that is a high risk for refeeding syndrome and actually happened. So if you guys are interested, we could talk about that one offline. So that one was, that was a great one, actually. So you've got your graphic that kind of breaks it down that, what happens. So refeeding syndrome typically happens from a starvation state. We are starving. We are using mostly our fat stores to provide the energy that we need to do the things we need to do. But we could also be using some of our muscle mass, our protein. So then we give them D5. Doctor ordered it, we hung it up, we give it up. So what happens inside the body is we start metabolizing that D5, and that's when things go to hell. So you've got higher protein catabolism, your gluconeogenesis really starts going up, then you get into the vitamin mineral deficiencies, and that's really what we're looking for. And that's what causes the problems with refeeding syndrome. The 3 major labs that we're looking at for dietitian-wise is the FOS, K, and MAG. Those are the ones that we really look at for refeeding syndrome because they cause problems. I'm going to turn it back on you guys. Why are we looking at FOS? Think about metabolism. If you don't know the answer, that's okay. I didn't know the answer when I was asked as an intern. Okay.
Well, that has to do with that whole Krebs cycle and the...
Yep. Yep. There's one molecule. What's our energy molecule? ATP.
Yeah.
ATP. And the P is the phosphorus. So if we don't have enough phosphorus to make ATP, then we're not going to make much energy. We're not going to have the potential to store that energy to use it in other places. Okay, so hypokalemia. What happens when you're hypokalemic? What are the clinical signs? They're there on the sheet. One of them is, anyway. We get tachycardic. So we don't want to get too low in our, and I'm going to say phosphorus, and I know that's wrong, potassium. I get them all mixed up in my head sometimes, and we don't want to get low in the K. And then, why are we looking at mag? This is one you guys are not going to know. So we look at magnesium because magnesium is necessary for the distribution of potassium in and outside of the cell. So it helps regulate that distribution. Magnesium is also necessary for many of our enzymes, which it's considered a cofactor, so it fits down inside. Remember the enzyme pictures, and it's got the little square box and the little round box, and it's a cofactor. Without the magnesium, then the enzyme doesn't work. So that's why we're looking at those three electrolytes on a regular basis. For the clinical side of it, so you hung a bag of D5 and we really don't know anything about this guy. They're totally out of it, intubated, and you notice that one in the next 12 hours they get tachycardic, they get tachypnic. Sometimes you can't tell that because they're on a vent. Sometimes they're not on the vent and they start breathing a little faster. Then we want to be suspicious this might be a refeeding picture. Might. It's not always true. But we want to catch it early to prevent the potential harm of the refeeding syndrome.
So
Go
just
ahead.
to clarify, because I've not heard this term
Uh-huh.
before, refeeding. So
Mhm.
this is something that can happen, somebody comes in from out who's not eating well, in a semi-starvation state, and then
Yes. We give them
something,
we
and
give
then
them carbohydrates,
Okay.
and which revs up. We'll talk about it in the next couple because I wanted to go a little bit more into depth with what's going on. It's not always the starvation patient, the one that looks like they just got out of Auschwitz.
Mhm.
It's not always that person. Sometimes they have been chronically malnourished for so long, and they look fairly normal. They don't look super wasted. You can't grab their clavicles like handlebars, those kinds of things, because they've got metabolic issues going on as well. And those are things when it get a little more complicated and the picture's not clear.
So would your gastric bypass patient be
Yes, they almost automatically go to the moderate risk category.
what about all these, like the keto diet and all that? Is that, or is this opening up a whole can of worms?
It is opening up a can of worms, but at the same time, I'm glad you asked. If you have the question, somebody else has it. Somebody else watching it later is going to have this question too. A keto diet, absolutely, because we're burning fat. That's no different than a starvation state. We're burning fat. And we have completely taken out food groups.
But I thought starvation was more you're burning your muscle and your protein, not your fat.
The muscle and protein are same.
Okay.
So you're burning primarily fat, your fat stores, when you're truly in starvation state.
Okay.
There's a couple steps in starvation. When we ideally talking about starvation, we are burning fat primarily. And that's why we lose so much of the fat, pads that we've got. But we are also burning some muscle. And how much muscle we burn is based off of how active we are. So you could have a cachectic patient that, they have very little muscle mass and very little fat mass, but they are kind of staying stable. So this is one that, yes, they don't look all that great, but they're going to hit that low plus kind of for the refeeding syndrome. And we're cautious, the dietitians, that we've got here, we're looking at it every time. Anytime we start a nutrition support, anytime we've got a person that has been at home and they're marginally managing, they can't shop for themselves, they can barely make it to the kitchen to put in their microwave dinner, you can get refeeding syndrome with an oral diet as well. But usually the onset is quite a bit longer than when we started a nutrition support patient. You're going to see it. Go ahead.
Sorry, is this something we should be screening for too? It's like, are you on a special diet? Are you?
No,
Or
that's
is
not your job.
Okay.
That's not your job. If that's where it's good for us, you know, we try to be visible out throughout the hospital, and that's not always true for, say, second shift or, you know, overnight. We're not always there, but it doesn't, I'm like, we try to be there, try to pass that on in the nursing communication, that this person, I think they need to see the dietitian, or they got some weird rules around food, or sounds like they're following an odd diet. But we do screen everybody that comes to the hospital. You guys are doing it anyway, and it creates the best practice alert, which then I get a consult, which means I really have to go see this patient. I really have to figure out what's going on and why did they think that. Sometimes it's based off of age. They get an extra point to that, you know, to that score if they're over 80. They automatically get a 1. We get a consult if they get to a 3. So that's the weight loss and the food intake and the, you know, how ill are they? How are we doing on time? I feel like I've been talking for an hour. Sorry. Okay. Whew. Nope, it's okay. So now you suspect that you have refeeding syndrome. You still had a question and I don't think I answered it. Okay, sorry.
Maybe I did.
Okay, so the next steps for you guys. Now what? So we have 3 labs have come down, we've added some type of glucose into their diet. What do we do? Well, we need to replace those electrolytes. That's your number 1 priority. We want things to work appropriately. Your number 2 is to add thiamine. It's a B vitamin. It is absolutely necessary. And it's why going through rounds, critical care, or even the interdisciplinary upstairs, if we see that these labs are starting to get a little wonky, or we notice that they're trending down and we've added D5, you know, there's a reason that we're asking for the thiamine. Your next step is to reduce the carbohydrates, wherever they come from, whether it's the piece of bread that I got pictured, because it was the only carbohydrate I could find. That was a pretty picture. But that might be the D5 that we're running. Can we half it? Can we reduce the rate? Those are questions to ask the physician, to alert and say, hey, this doesn't seem right. Okay? And your next one is, but why? Why do we need thiamine? Why am I talking about thiamine? This seems really weird. Okay, so it's not highlighted, so I'm going to point it out on the screen. Thiamine is necessary, so this is the Krebs cycle, or the TCA, or the citric acid cycle. There's a couple different names for it. This is back to biochem. I'm sorry, but it's necessary. This is why I became a dietitian. I love this stuff. It's weird. So going into the Krebs cycle, you take your pyruvate molecule and you make it into 2-acetyl-CoAs. You absolutely have to have thiamine in this complex, otherwise this doesn't work. So then if this doesn't work, then we look at a different pathway, and we only get the 2 energy molecules out of it, the 2 ATPs, or what is it 4? Sorry, I'm having a moment, as opposed to the 30-something we get out of the Krebs cycle. If this doesn't have thiamine, this isn't going to happen. Okay. There's one other spot on the Krebs cycle, which is down here, where we get our alpha-ketoglutarate to our succinyl-CoA. You don't need to remember that. There's 2 spots in the Krebs cycle. But I know nursing, they always ask me why. So I'm like, okay, I'm going to tell you why. This is also one of those that absolutely has to have thiamine to work. Thiamine is a B vitamin, which it's on the water-soluble side, so we don't store it. We have some in our system,